E aqui eu já começo a falar exatamente isso. Hoje nós vamos trazer uma aula interessante feita pelo Dr. Philippe Pibarot, que é uma das maiores referências na ciência mundial da cardiopatia estrutural. Ele, que é canadense, fez essa aula com a gente e logo após a aula vai estar conosco aqui trabalhando junto e respondendo algumas pequenas perguntas para que a gente possa ter uma interação melhor. Então, abordando um pouco mais sobre as lições aprendidas dos trials bem famosos, o COAPT e o MITRA-FR, com vocês, Dr. Philippe Pibarot.
Hello, I am Philippe Pibarot from the Quebec Heart and Lung Institute in Quebec, and today we'll discuss the MITRA-FR versus COAPT results and the lessons that we can learn from two trials with diametrically opposed results, as you know. So I do have some disclosure I would like to mention before we get started. They are mentioned here. We are involved in several TAVR trial in particular, and in some mitral intervention study as well. So you know the results of these two trials that were published both in New England Journal of Medicine. MITRA-FR was published in August 2018, and COAPT a little later in September. As you see, the results with regard to the primary endpoint, which in MITRA-FR was the composite of all-cause death and heart failure hospitalization, well, there was absolutely no difference between the two groups. So the patients were randomized to heart failure therapy only versus the group that was randomized to mitral clip intervention. In the COAPT trial, well, the results were very different. As you see, heart failure rehospitalization was dramatically reduced in the device group, so in the mitral clip group versus the control group, and even all-cause mortality was significantly reduced with intervention with the mitral clip. So you have two trials, the one on the left, MITRA-FR, that is very completely negative, and the one on the right, COAPT, that is very positive. And that's supposed to be two trials targeting the same population with the same device. So we have to explain this big differences, and that's what we attempted to do in this review/opinion article that we published in 2019 with my good friend Jerome Bax and Victoria Delgado. So if we look first the study design and the differences between the two trials, yes, they targeted the same population in the sense that it was all patients who were symptomatic heart failure, function class 2 or more, and with evidence of heart failure. The definition of heart failure was slightly different in the two trials. So to get into MITRA-FR, you needed to have at least one hospitalization for heart failure within the past 12 months, whereas in COAPT, you have also this criteria of hospitalization in the past year, but it could be also that you had a BNP more than 300 or NT-proBNP more than 1500. So it's and/or. So if you had BNP no hospitalization, you're eligible. Whereas in MITRA-FR, you needed to have a heart failure hospitalization in the past year. The other thing was the criteria for the MR severity, and that's a very important one. In both trials, the patients who were eligible were those with a secondary MR. Primary MR was excluded. But in MITRA-FR, it was defined as an EROA of 20 millimeters square or more, which kind of recruited patients with moderate or severe MR. Whereas in the COAPT trial, the criteria that they used were more severe, let's say. And so they were recruiting more the patients with moderate to severe or severe MR, so 3 or 4 plus. Whereas MITRA-FR, it was 2 plus or more. So to summarize, MITRA-FR was 2, 3, 4 plus that were eligible, whereas COAPT was more 3 and 4 plus. Important differences. In terms of LV function, MITRA-FR, they allowed patients to enter if they had an LVEF between 15 and 40%. So including mild, moderate, and severe LV dysfunction. Whereas in COAPT, it was slightly different. You see, it's instead of 15 to 40%, it's 20 to 50%. So somewhat better LV ejection fraction. And also there was a criteria that the LV and systolic dimension needed to be less than 70. So they kind of excluded the patient with very bad LV function in COAPT, where they were included in MITRA-FR. Study funding. Well, MITRA-FR was an academic study sponsored by the government of France, Ministry of Health. Abbott has some contribution in the sense that they were proctoring the teams and they provided for free almost all MITRA clips. Whereas COAPT was an industry, 100% industry sponsored trial, so funded by Abbott. I'm not sure it has influenced the results, but still this is something to mention because all events in both groups, in both trials were adjudicated and carefully reported. Now, what are the similarities and differences between MITRA-FR versus COAPT? For the study design, we already discussed that, but this is a table that we provided in the paper that we published with Victoria Delgado and Jérôme Bax in European Heart Journal of Cardiovascular Imaging. And well, there are several differences already mentioned, but I think again the most important are those that are related to the MR severity. And you see that in MITRA-FR again the criteria for getting into the trial, EROA of 20 or more and regurgitant volume of 30 or more. Whereas in COAPT, they selected patients with more severe MR at baseline. You see the EROA criteria is 30 versus 20 in MITRA-FR, and the criteria for regurgitant volume is 45 versus 30 in MITRA-FR. So it's an important difference here. And in terms again of LV ejection fraction, 15 to 40% for MITRA-FR versus 20 to 50% in COAPT. And I think these two factors may have changed at the results of the trials, and they may explain in large part the differences that we have between the trials, because COAPT recruited patients with more severe MR and maybe less advanced LV dilation dysfunction, whereas MITRA-FR, they selected patients with a wider range of MR severity, with patients maybe not having so much MR, but more advanced LV dysfunction, okay? So this is the study flow chart for the MITRA-FR. Initially, they screened 452 patients, so 145 were screen failure. They end up with around 300 patients who were randomized, about 150 patients in each group. And this is the intention to treat comparison. Follow-up was quite good. Completeness of follow-up was obtained in 99% of the patients. And so they ended up with a comparison of per protocol analysis of about 109 patients in the MITRA-clip group versus 137 patients in the control group, so the medically treated group. For COAPT, much larger number of patients, but also, as you see, a very large number of patients were screened. 1,576 patients were screened to finally enroll 665. So there was a very high rate of screen failure. What it tells here is that, yeah, this is a highly selected population because you screen 1,500 or so to get 600 or so. So it's highly selected, and that's why it took a lot of time to recruit this population. And then these 600 patients or 665 were randomized, same, with about 300 patients in each group. Okay, and these are the similarities and difference again between MITRA-FR and COAPT, but here with regard to the baseline characteristics. So what you see here is that the main differences, I mean, are coming from the differences in the inclusion-exclusion criteria. What you see is that there were actually relatively more patients with moderate to severe or severe MR in COAPT than in MITRA-FR, because again, MITRA-FR allowed patients with maybe moderate MR to get into the trial, whereas they were excluded in COAPT. Also, what we see is the LV and diastolic volume index, so the LV volume was kind of smaller in COAPT versus MITRA-FR. Again, maybe because there were some differences in the exclusion criteria, and COAPT recruited maybe more patients or less patients with more advanced disease. Also, the LV ejection fraction, well, there were not much difference in this regard between the two trials. So in terms of study outcomes, what are the differences? Well, I would like to highlight some. Procedural success overall was good in both trials. You know, you have 96% procedural success in MITRA-FR, 98% in COAPT. What is interesting to look at is the number of clips implanted, and this is an average per patient. You see that in general, in COAPT, you had more, larger proportion of the patients who had 2 clips or more. You had like 55% having 2 clips, 8% having 3 clips, and 0.3% having 4 clips. Whereas in MITRA-FR, you know, most patients got 1 or 2 clips, you know. So there seems that maybe in the COAPT trial, they have been a bit more aggressive in general with the number of clips, you know. And when you look at the results in terms of correction of MR, the proportion of patients who had a post-procedural MR of moderate to severe or more, so 3+ or more, which is actually a failure, was fortunately low, but tended to be more frequent in MITRA-FR versus COAPT. Maybe because they were less aggressive, maybe because the patients were at different baseline characteristics. But more importantly, when you look at the results at 1 year, in MITRA-FR, 17% had a MR severity of moderate to severe or more, so a kind of a recurrence of the MR. So that's an important issue, whereas in COAPT, it appears stable with about the same proportion that we had at the time of the procedure. So what we can see is that from these results, the sustainability, the stability of the correction of the MR in the mitral clip group appeared to be better in COAPT versus MITRA-FR. Okay. In terms of mortality, well, what we see is that mortality at 1 year was similar in both groups, in mitral clip group versus control group in MITRA-FR, no difference. Whereas in COAPT, interestingly, the mortality is similar in the control group of COAPT versus the control group of MITRA-FR. The difference is really in the intervention group, where the mortality appears to be lower in COAPT versus MITRA-FR. In terms of heart failure hospitalization, it's interesting, again, similar rate at 1 year in control group versus intervention group in the MITRA-FR. But in COAPT, well, what you see, it's a twofold difference. There is first more heart failure hospitalization in the control group of COAPT than in the control group of MITRA-FR, and less heart failure hospitalization in the intervention group of COAPT versus the intervention group of MITRA-FR. And so in the end, there is a very big difference in heart failure hospitalization between the control and intervention group of COAPT. So that's the main difference in outcome. And again, I'm showing you this major differences between MITRA-FR and COAPT in terms of the primary endpoint, which was essentially composite of all-cause mortality or heart failure hospitalization at 1 year, whereas in MITRA-FR, the two curves were perfectly superimposed, whereas in COAPT, there is a major differences, especially in heart failure hospitalization, but also in mortality. So some people came up with this concept to explain the difference, this concept of disproportionate MR. And it is it is an attractive concept, and this is the following. So if you eventually put the severity of MR represented here as the effective regurgitant orifice area versus the LV and diastolic volume, there should be a relationship. So if you have more severe MR, you're going to have more dilated LVs and therefore larger LV and diastolic volume. Makes sense. And there should be a proportionality between the MR severity and the degree of LV dilation. So what Packer and colleagues, and essentially this is a concept coming from Paul Graeber, is that, well, if you are here in this left, the top left section, this is in fact a severe and disproportionate MR, meaning that you have a severe MR, but the ventricles are not that dilated, So it means that it's an MR that is disproportionate versus the LV dilation. And this is the situation or the context probably of the COAPT trial. The COAPT trial will be in this area. And of course, you may hypothesize that if you have a severe disproportionate MR, this patient will be good responder to an intervention that targets the MR, so good responder to MITRA-FR intervention. And that's why the results of the COAPT trial were so positive. On the other end, the patients who have like a more severe but proportionate MR, so where there is a severe MR, but the ventricle is also very dilated, that would be the case of MITRA-FR. Well, these patients may not respond as well to a therapy targeting the MR because the ventricle is quite dilated. And then you have, of course, the mild to moderate MR, who probably are not good responders because here the MR is maybe a more bystander and not playing an important role to the heart value. And so what the authors, propose that, of course, if you have a proportionate MR, and in fact, well, a more advanced maybe LV dilation and dysfunction, well, maybe the mitral clip is not the best way to go, and we should more optimize the medical therapy, eventually propose left ventricular assist device, etc., to try to get a positive remodeling of the left ventricle. On the other hand, if you have a disproportionate severe MR, such as in COAPT, then of course, a therapy with mitral clip will improve the LV function and the outcome of the patient. And I may surprise you, but I don't like this concept, and I will tell you why. So this is a paper that provides maybe further support to this concept of disproportionate MR. This is from David Messika-Zitoun. They analyzed the data of MITRA-FR and COAPT, and they actually show some different subgroup analysis according to MR severity and to LV and diastolic volume. And yes, they identify some subgroups where, for example, the patients who have a ratio between the effective regurgitation orifice area and the LV and diastolic volume that is more than 0.15, meaning that you have a more severe MR in relation to the LV dilation. These patients, they are more on the disproportionate severe MR side, also on the COAPT side, and same those who have a large ERO with a relatively small LV and diastolic volume. So again, this is evidence of disproportionate MR. They co-localize with this area where we have the COAPT. Whereas the patients who have like maybe less severe MR with more dilated ventricle, well, these patients are more on the what we call the proportionate MR area here, and with the MITRA-FR. So I will tell you why it does not necessarily make sense. If we go now to the echo results of the COAPT trial, okay? Well, that has been published by Federico Ash, where actually the collab for the COAPT trial. We see that there is the numbers do not fit, because if you calculate the average total stroke volume, so this is, just the difference between the LV and diastolic volume and the LV and systolic volume, you would get something around 60, 70 ml, okay? Okay, and then the average regurgitation volume should be between 30 and 60 ml, most patients above 45 ml, because this was the inclusion criteria in COAPT. And then if you calculate the forward stroke volume, so what goes through the aortic valve and in the aorta, the true forward stroke volume, which is the difference between the total stroke volume and the regurgitation volume, this would only left you with 10 to 20 ml, so almost zero. Does that make sense? You cannot have a stroke volume of 10 or 20 ml and be alive. So there is something wrong here. Most likely, I think, and everybody now agrees with that, is probably the LV volumes were kind of underestimated in COAPT. As we know very well, the echocardiographer knows that when you use the Simpson method for LV volume, Simpson is a great method to assess the fractions, but it underestimates the volume. So the volume might actually be larger than what is mentioned in the paper. That's the first thing I want to make. And the point I would like to make here is that instead of talking about disproportionate MR versus proportionate MR, we should talk about disproportionate LV dilation. So my point here is that we should call the disproportionate MR a proportionate LV dilation, and the proportionate MR more a disproportionate LV dilation, okay? I think this is the probably a new concept, but because it does not make sense to have a severe MR and no LV dilation, especially when it's something chronic. I always say to my fellow, if you have a severe MR, you need to have an LV dilation that is also probably severe. Otherwise, there is something wrong. So I think the COAPT was more a proportionate LV dilation. In other words, the LV dilation was proportionate relative to the MR severity, not the opposite. And in MITRA-FR, you had probably more disproportionate LV dilation. So the LV were more dilated than we were expecting from the MR severity, which tells you that in MITRA-FR, the heart failure was probably more determined by the left ventricular disease, and the MR is probably more a bystander, whereas in COAPT, on average, the heart failure was more determined by the MR per se and less by the LV disease. So I think it's important to keep in mind. And this is a figure that we included in our paper, and I think it summarized, the utility versus futility of the mitral clip according, and we need to include, to integrate, and balance the severity of MR versus the degree of LV dilation dysfunction. So if you have not very severe MR, mild, moderate MR, well, probably the mitral clip will be futile, regardless of the severity of LV dilation or dysfunction, because the MR is maybe not severe enough to get a benefit from an intervention that targets the MR. Now, if you have a moderate to severe MR or severe MR, then this is where you need to look at the LV systolic dysfunction. If you have mild to moderate or moderately severe LV dysfunction, probably you're going to benefit from mitral clip. If the left ventricular disease is too advanced, you have LVF that is less than 20% of very dilated LV ventricle, maybe it's too late. So this is an example of a patient with secondary MR. The video clips are not playing, but it shows a severe functional MR, secondary MR at baseline, successfully corrected by mitral clip, but we had to put 3 clips. And you see, even if the video clip are not playing, that there was a good positive remodeling at 1 year. You see the LV volume that decreased markedly. So I think in the timing of intervention in the disease course is very important. Timing is everything, right? And I think, the COAPT, they targeted a timing that was probably more optimal than MITRA-FR. MITRA-FR, they went maybe a bit too far. So COAPT targeted patients with more severe MR, not too dilated LV ventricle, whereas MITRA-FR were maybe including some patients who had ventricle were too advanced. And reshape is probably in between in this category. So the timing of intervention in the course of the disease is very important. So in conclusion, MITRA-FR and COAPT, yes, targeted the same disease entity with the same device, the mitral clip, but COAPT enrolled a subset of patients who had more severe MR and maybe less advanced ventricular disease compared to MITRA-FR patients, and that may explain the difference. And in terms of clinical implication, which is of course very important, I do believe that the mitral clip procedure indeed reduces heart failure hospitalization and mortality in patients who have the following criteria. Moderate to severe MR or severe MR, so at least moderate to severe. We should not include those with mild or moderate MR. Defined as an ARO more than 30 and all registration volume more than 45. So you need to have an MR that is severe enough to benefit from the mitral clip. The second criteria is an LVF between 20 and 50%, with a LV and a systolic diameter that is less than 70, because beyond 70, it's a bridge too far. And we have persistent heart failure symptoms despite optimal according to guidelines, medical therapy, including resynchronization, including coronary revascularization. So first, you need to optimize the heart failure therapy before eventually considering the mitral clip. And the goal of the procedure should be to obtain, and that's the minimum goal, an acute reduction of the MR severity to less than mild, less or equal to mild. So you need to have a maximum of 1+ residual MR. If you have more, then you know that it's not going to work. And so on this, obrigado. Thank you very much.
Acho que são aulas como essa que fazem a gente ficar realmente feliz pelo que a gente faz. Como vocês puderam ver, uma personalidade no mundo científico dessa grandeza, falando um aspecto muito interessante de pacientes que a gente encontra no dia a dia. Eu vou chamar de novo o Dr. Alexandre Bisaide para a gente poder discutir algumas coisas sobre essa realidade desses trabalhos que o Dr. Philippe acabou de trazer para a gente. Dr. Alexandre, o senhor que é um intervencionista de mão cheia, talvez um dos mais famosos do país, o tratamento transcatéter desses pacientes com insuficiência cardíaca, o senhor acredita que já é uma realidade, está por virar uma realidade?
Bom, eu gostaria que fosse uma realidade muito mais presente no nosso país, né, Tiago? Acho que nós ainda temos alguns estraves, algumas limitações, e a principal delas é realmente a questão financeira, né? Esses são dispositivos ainda caros no Brasil e requerem um grau de treinamento muito específico, acurado e muitas vezes demorado. É bem diferente do espaço aórtico, quer dizer, a estenose aórtica com a TAV foi mais facilmente conquistada e mais facilmente divulgada e disseminada, né? A Mitral é bem diferente. Vocês veem que o aparelho mitral é muito mais complexo e talvez várias providências precisam ser tomadas e vários approaches, né, precisam ser tomados, não apenas um só. Então, cada caso é um caso bem diferente do outro. Muitas vezes nós vamos precisar de fazer uma anuloplastia, muitas vezes precisa de se aproximar as cúspides posterior e anterior, como é o caso do MITRA-Clip, e chama edge-to-edge, né, em inglês, e muitas vezes precisamos substituir a válvula. Então, o aparato mitral é muito mais complexo e vai requerer várias soluções dependendo do problema. Então, eu acho que o espaço mitral ainda não foi conquistado. Eu acho que esses pacientes são mais frequentes e mais prevalentes do que a própria estenose aórtica, que hoje já está muito bem disseminada, como eu disse. E muitas vezes o problema não é da mitral, a maioria das vezes o problema é secundário, né, da dilatação do ventrículo esquerdo devido a, como você falou, um quadro de insuficiência cardíaca. Então eu acho que muitos passos já foram dados, mas vocês veem, o único dispositivo percutâneo não cirúrgico que nós dispomos hoje no Brasil é o MITRA-Clip, que ainda é caro, com poucos centros realizando e com todas essas nuances que o Pibarot falou, né? Então, você tem que saber selecionar bem para que o paciente se beneficie melhor desse dispositivo.
Brilhante, doutor Alexandre. Eu também acho que esse é o aspecto interessante. O professor acabou de conectar com a gente e já a gente vai trazer ele para poder conversar aqui, fazer umas pequenas perguntas para ele e ter o grande privilégio de ter uma pessoa como o professor Philippe Pibarot para poder discutir com a gente sobre os trabalhos que ele publica rotineiramente e discute no dia a dia clínico como ele. So, professor, can you hear me? I think your phone is mute.
I can hear you as well, and my phone is not muted.
Okay. I listen to you at now. So, welcome again to take time for conversation with us about that brilliant presentation. So, I have a question to make to you, and after that, I will take the words to the Dr. Alexandre Bisaide to ask something too. So, my question is, okay, we understand about the new concept of MR, disproportionate MR. So, the question is, actually, with the new medications like sacubitril, ivabradine, do you think that new approach, clinical approach, can change the results like the COAPT or MITRA-FR with the new medications?
Well, first I would like to thank you and your organization for having me in your great meeting. Thank you so much. Yeah, I mean, it's interesting, and it's interesting and moving target, right? Because the medical therapy of heart failure is evolving, it's progressing, and so we have a new medication, as you said, to maybe better manage our patient with heart failure, with systolic heart failure, and eventually concomitant mitral regurgitation. And I think, you know, maybe the role or the niche of MITRA-Clip is really for patients with heart failure who have optimized medical therapy. And optimized medical therapy includes all possible pharmacotherapy, as well as eventually resynchronization, etc. It should be really optimized. We should not consider an intervention such as MITRA-Clip or equivalent if we have not yet optimized the medical therapy in the patient. The other thing I think that is important to consider is to try, although it might be difficult, and I try to address this in my presentation, maybe to identify what is the main contributor to the heart failure. Is it more the left ventricular disease, or is it more the mitral regurgitation? And that's why I think we should target patients who have a sufficiently, let's say, severe MR. So at least patients who have a 3 or 4 plus MR. Because if you target patients, if you put a MITRA-Clip in patients who have mild to moderate MR, well, of course, you know, the benefit of the intervention will be less, and there is a higher risk for having a futility. Whereas if you target the patients with more advanced MR, as it was done in COAPT trial, and maybe exclude patients who have too advanced left ventricular disease, so patients with very low LVEF or very dilated left ventricle. And again, after optimization of medical therapy, then that would be maybe the key of success.
Great, amazing. Alex, do you have any question?
Yes. Bonjour, Philippe. Merci. Thank you so much for joining. This was a brilliant talk.
Thank you.
So I have a question to you. When I think about MITRA-Clip, I think about secondary heart. I think that those are the patients that perhaps can benefit the most, and I think you made very clear in your presentation, of course, that those with some left ventricle reserve, not so bad ventricles together with an important MR, those are the ones that will benefit the most. My question to you, after this more recent evolution and interaction of MITRA-Clip new devices, such as the XTR, the NTR, do you think I can adventure myself to indicate MITRA-Clip to more degenerative cases? Do you think that with the new devices, we can be a little bit more successful with somehow more fibrotic valves and with a little bit more difficult anatomies?
That's a very good question, Alexander. I think I agree with you. The best patient or the primary target should be secondary MR. That's really, you know, that's where maybe the MITRA-Clip will help us the most, because it's really more a lack of coaptation. The leaflets are morphologically rather normal, and the problem is that they do not coapt anymore. So, you know, re-coapting the leaflets make a lot of sense. Although it does not address completely the pathophysiology of the disease, because as you know, in secondary MR, in functional MR, yes, you have a lack of coaptation, but also you have a problem of dilation of the mitral annulus. And of course, the MITRA-Clip does not fix that part. And that's why sometimes after MITRA-Clip, we have persistence or recurrence of MR. It's often in the patients with very dilated annulus. And there are some procedures that are currently under validation that are transcatheter procedures that allow like annuloplasty, you know, transcatheter annuloplasty. So maybe at someday we're going to use an hybrid approach where we're going to do the MITRA-Clip plus maybe a restrictive annuloplasty to bring down the size of the annulus. And remember, where we have to think where the MITRA-Clip comes from. It comes from the idea of Alfieri, you know, Ottavio Alfieri and the Alfieri stitch. But Ottavio himself, who is a good friend, has shown that the Alfieri stitch, it works as long as you do an annuloplasty at the same time. So with the MITRA-Clip, we are still incomplete in the process. Now, with the new devices, so the XTR, etc., and also the Pascal, which is another type of device, can we address more the primary/organic MR? Maybe, but it's going to be a bit more challenging, and maybe we're going to be sometimes disappointed by the results. And so I would only consider addressing this patient if they really are not eligible for a surgery. Because if they are eligible for a surgery, even with somewhat higher risk, I think they will be better served by a surgeon. Because it's not only, you know, clipping the leaflet. And when you look at patients working on a Marfan, on a Barlow disease, or on a posterior mitral valve prolapse, it's you know, they have to do many things. You know, they have to do the resection, they have to do the annuloplasty. So it's not only one procedure. So I think, you know, it's really, if we start to address the primary MR, it's going to be really more a palliative measure, and only for those who are inoperable. That's very important.
I fully agree with you. Tiago, I know that we are short in time, but if you allow me, I have one more question to Philippe.
Please.
So Philippe, for many, many years, we believe that the genesis of MR, mitral regurgitation, mainly secondary regurgitation, was due to bad ventricle, right? So the left ventricle played a very important role in the genesis in the pathology or physiopathology of mitral regurgitation. More recently, I start to hear new concepts that the atrium plays an important role. So can you share, as one of the best echocardiographers in the world, what have you seen that, or what kind of observation you have with echo that shows that the atrium plays an important role in the MR as well?
Yeah,
great question.
That's very interesting. I think, yeah, you're right. I think we have, for many years, including myself, we've said that, you know, the secondary MR, functional MR, was more a disease of the ventricle than a disease of the valve. And these concepts have changed. And as you mentioned, I think the left atrium has an impact, as a contribution to the disease, because when you have a very dilated left atrium, and especially when you're in AFib, and then you start having, you know, a dilation, and the dilation is contagious. It also will impact the mitral annulus. And as we just discussed, one of the contributors to the secondary MR is the dilation of the annulus. So if the left atrium dilates, the mitral annulus will dilate, and the tethering on the leaflets will increase. So it's really an interaction between the left ventricle, the dilation of the left ventricle, the dilation and atonicity of the left atrium. So with echo, I think we have to, of course, we need to look at the ventricle, but we also need to look at the size of the left atrium. The mitral annulus should be carefully measured. And maybe also there is a role of left atrial strain in this regard. You know, I think this is another maybe factor that may be involved. And then I will go one, if you allow me, I will go one step further. What we found, and this is one of my colleagues, when he did his fellowship at the Mass General with Bob Levine, Dr. Jonathan Baudouin, and he published several papers recently in JACC, that it shows that actually the mitral valve is not normal in functional MR. Actually, there is a lack of, usually, for example, if you have a severe aortic regurgitation, okay, the ventricle will dilate, and sometimes dilate to very important size, right? But these patients, they do not develop MR. They do not develop functional MR, although they have huge left ventricle. But if you have a myocardial infarction, then you will develop MR. And therefore, there is actually an alteration of the signaling that makes, in fact, the mitral valve, when you have a dilation of the ventricle, it has the ability to grow, so to compensate for the dilation of the left ventricle. But when you get the myocardial infarction, this ability to grow, to have a growth of the mitral valve leaflet is lost. and therefore you have the tethering and lack of coaptation. So now my colleague is working on a pharmacotherapy trial in order to try to restore this, let's say, ability of the mitral leaflet to grow and to adapt to a dilation. So in fact, secondary MR is not only a disease of the ventricle. Finally, it is a disease of the ventricle, of the left atrium, and of the mitral valve.
Yeah, that's very interesting. And I have to say that I haven't documented atrial remodeling so well as we did for the Millipede study. Millipede is a device that we tested here in Brazil in part of the first-in-man study, which is, you know, some anchors and screws that you put in the mitral to promote annuloplasty. And it's funny, after, when you eliminate MR, the atrial remodel in a way
positive remodeling, yeah.
Exactly. It even touched some of the anchors. So it was really impressive to me. So let's not ignore left atrial.
Absolutely.
We focused a lot on left ventricle, but I think that the whole apparatus will play an important role.
Yeah, it's a complex disease.
Thank you so much. I think that Thiago might have to invite the next speaker, but I'm very pleased and thankful for your participation and for you taking the time to help us with education in Brazil. Thank you so much.
Obrigado.
Merci, Professor Pibarot. Thank you for your time.